A DHIS2 dashboard shows a spike in maternal deaths. Is it real or is it a data entry error? You have just 48 hours to decide. In health systems, decisions affect lives, resources, and public trust. But good decisions are never based on dashboards alone. They are based on the ability to question, verify, and interpret data before acting. Welcome to episode 12. Hello and welcome back to Digital Literacy for the Health Workforce series. My name is Vivian Korir, founder of First Elevate Africa. Today we explore one of the most important digital capabilities in healthcare, using data to make sound decisions. If you enjoy practical, Africa-focused digital health learning, please subscribe, like, and share. Let's begin. By the end of this episode, you should be able to define health data, distinguish patient data from aggregate data, apply the DIKW model, judge data quality, interpret dashboards critically, and apply data protection and ethical principles in decision making. These are practical skills that you can use immediately in your daily work. Where does today's episode fit? This is Module 3 titled Digital Skills in Practice. Today we shall look at using data for decision making. Previously we've looked at Introduction to Digital Health in the same module. Also we've looked at Core Digital Skills under Module 2 and Foundations of Digital Literacy under Module 1. Coming up in the future is Module 4 on Future-Ready Digital Skills, where we shall look at, among others, AI fluency. What's health data? Health data is any recorded fact about a patient, a facility, or a health system. It may exist on paper or digitally. It exists in three forms: clinical or patient data, facility or operational data, and aggregate or population data. Remember this important principle. A number inside a computer system or a device is a claim. It is not an automatic fact. It must reflect what is happening in the ground. Fatima's story illustrates this perfectly. The system shows 400 malaria test kits. The shelves show 180 malaria test kits. Which do you trust? Always reconcile digital records with physical reality. The data journey, DIKW, data, information, knowledge, wisdom. Data alone does not make decisions. It progresses through 4 stages. First comes data, which are raw facts. Then information, that is data placed into context or processed data. Then knowledge, which is understanding why something happened or understanding the information. And finally comes wisdom, that is choosing the right action or using data for informed decisions. Joseph sees 0 A and C visits. Is that really a 0? No. He investigates and discovers the report was never submitted. Good decisions require moving beyond numbers to understanding them. Patient level versus aggregate data. Not all data is treated the same. Patient level data identifies individuals. It requires strict protection, consent, and legal safeguards. Aggregate data combines many records or many patient level data and supports planning and reporting. Be careful. The moment identifiers are added to an aggregate request, it becomes patient level information. Let's look at Grace. She's an M&D officer in Dar es Salaam. A major donor requests facility-level maternal health extract, but also individual patient identifiers to allow longitudinal tracking. A supervisor says find a way to comply. But she knows the data protection laws in her country, so she only shares aggregate data. The lesson: data protection obligations are not negotiable, even under donor pressure. Know your law and propose alternatives. Grace's story reminds us that pressure from donors or supervisors never overrides data protection laws. Know the law, protect the patient, offer safe alternatives. Data quality. Before using any number, ask 3 questions. Is it accurate? Is it timely? Is it verifiable? Even if one answer is no, that data is not ready for decision making. Accurate means the number reflects what actually happened. Timely means it's available in time to inform decision, and verifiable means it can be tracked back to source record. Missing any of the three markers makes a dashboard unsafe to use. Michelle's dashboard showed rising maternal deaths. Instead of reacting immediately, he first verified the data. Remember, dashboards raise questions. Verification provides answers. Capability continuum. Data and information literacy. Data literacy develops over time. First, literacy. You can read and enter data correctly. Then competence. You can troubleshoot and reconcile a problem. Third, fluency. You can validate, document, and interpret data in context. Finally, dexterity. You adapt and propose workaround under real constraints. Amara had no technical support. Her app wouldn't sync. Instead of panicking, she documents the issue, protects the data, and finds a safe workaround. That is digital capability. The data feedback loop. Data should never travel only in one direction. It should flow from collection to aggregation to analysis to decision, then back to the source or back to the frontline health workers. When health workers never receive feedback, reporting becomes a burden. When the loop closes, data becomes a powerful improvement tool. How do we bring all this together? Data for decisions in practice. Notice the common habit across all these three examples. Amara verifies before escalating. She checks offline storage before assuming data loss, documents the failure with evidence, escalating with a proposed workaround. Nasnuru verifies before sharing information. She spots an urgent official-looking data request, verifies identity through a known channel, declines to share patient data on trust alone. Joseph verifies before correcting data. He questions zero that doesn't match reality, traces it back to the paper register, fixes the process, not just the number. Different countries, different professionals want consistent practice. Verify before you decide. Dashboards for decision making. Dashboards are powerful, but they are not decision makers. Whenever you see an unusual number, first, read. Does the number look plausible at a glance? Second, question it. What would explain an outlier? A real event or a data error? 3. Verify it. Check the raw register or source system before you can act or present. A dashboard is a decision support tool, never a decision maker. Data protection laws. Across Africa, different countries have different laws, but the principles remain the same. Consent, purpose limitation, data minimization, legal compliance. These are core principles. A funder's agency does not override a patient's legal protection. Good governance protects both patients and institutions. Data quality, governance, and ethics. Governance includes the policies and rules that keep data trustworthy. Ethics are the judgment you apply in the gray areas policy doesn't cover. Before submitting any report, pause and ask, is it complete? Is it plausible? Does it match the original records? Joseph fixes not only the missing report but also the reporting process, preventing the same mistake from happening again. That is continuous improvement. The bigger picture, LMIC realities, data as the new oil. People often say data is the new oil. That is true. Data is valuable but useless unless it is refined. Across many African health systems, data comes from multiple systems, multiple formats, and varying levels of quality. The professionals whom can harmonize, interpret, and communicate that data become powerful contributors to policy and planning. Before we look at the quiz, take a moment to pause and reflect. Think about the last report you submitted. Did you verify it against the source records? If something looked unusual, would you know who to contact and how quickly? Developing digital capabilities starting with asking better questions. Here's a quiz to test your understanding. I'll read the questions and provide the answers in the next slide. Fatima's system shows 400 RDTs in stock. Her physical count shows 180. What should she do? A. Trust system figure, cancel the resupply. B. Trust a physical count, say nothing. C. Document the count, update the system, flag the gap. D. Wait until next month's stock take. Question 2. Which of these data requests needs the strictest protection and consent? A. Extracts with patient identifiers for tracking. B. Facility level malaria positivity trends. C. District level aggregate ANC coverage. D. National summary dashboards for donors. Question 3. A HMIS2 dashboard shows a sudden spike in an indicator. What's the right first move? A. Present it immediately as confirmed fact. B. Dismiss it as a likely data entry error. C. Remove the indicator from the dashboard. D. Verify it against source register. Here are the answers. How many did you get correct? Question 1 is C. Document the count, update the system, flag the gap. Question 2. It's A. Extract with patient identifiers for tracking. And question 3 is D. Verify it against source register. In our next episode, Digital Skills in Action, all the familiar characters we've seen today will return for a practical scenario-based recap across the digital capability continuum. If today's episode helped you think differently about data, please like, share, and comment with the scenario that resonated most with you. Until next time, remember, good decisions are not made by dashboards. They are made by people who know how to question, verify, and interpret the data behind them. Thank you for watching. Until next time, goodbye.